doctors and their management. Without any delay, I would like to call upon Dr. Mulidhar Sharma sir, STM would be to take over the session. Welcome to you, sir.
Okay. Now, we had discussed about the constipation and some of the consequences of the constipation. Now, one more the consequences of the constipation related issue is a megacolon. Now, a definition of megacolon is when the diameter of the colon is greater than 6.5 centimeter in the rectosigmoid region or greater than 8 centimeter in the ascending colon. So, normal range would not be more than that. Now, for the practical purposes, they are classified into acute megacolon, chronic megacolon, which includes congenital, acquired, and idiopathic causes, and toxic megacolon. Acute megacolon we have already discussed in case of the obstruction, pseudo obstruction, like where there could be a positive pressure developed due to the ileocecal valve closure and then the obstruction in the distal area. That part we have already discussed. The other part is about the chronic megacolon of congenital and acquired. That's what we are going to discuss next. In the chronic megacolon, the causes could be many, and the causes could be classified as neurological disorders, systemic diseases, or metabolic disorders, and then of course congenital, the Hirschsprung's disease. Then there is one more category called as idiopathic. Neurological causes like patients with the chronic diabetes and particularly the metabolic syndrome, one of the complication of the diabetes mellitus is metabolic syndrome where the autonomic nervous system functions would be impaired and hence the movement of the food in the gastrointestinal tract becomes sluggish and hence the patient would have a constipation symptom and in due course of time that constipation results in fecolis and many times it's aggravated by patients' habit of consuming some purgatives. So if they consume purgatives regularly, that aggravates the problem and this results in a dilatation of the colon. Similarly, Parkinson's disease, like where again there is a neurological pathology and there it could be due to a incomplete evacuation due to the skeletal muscle activity. See, for the evacuation of the bowels, it's not only the autonomic nervous system which is important, the skeletal muscles also are required and if they are not functioning properly that can result in an incomplete evacuation and that incomplete evacuation can result in the megacolon. So is the case in spinal cord injury too. In the spinal cord injury it's the same issue like where there will be a incomplete evacuation due to the skeletal muscle inactivity. Amyloidosis also is a deposition disorder which results in reduced muscular activity. Then systemic diseases like SLA, scleroderma, rheumatoid arthritis, these conditions can result in a megacolon either as a direct effect on the nervous system or as well as many times it could be a consequence of the medical treatment given for the rheumatoid arthritis or simply because of the pain the patients may not be having a proper evacuation and so in multiple causes can result in a very chronic constipation and that results in the megacolon. Then metabolic disorders like hypothyroidism, hypokalemia, porphyria, pheochromocytoma, these also can result in irregular bowel movements and even the consistency of the stools can change in these conditions and hence that can result in megacolon. Congenital, of course, we will Hirschsprung's disease we will discuss separately where there is a aganglionic lesion as such. Now, chronic megacolon again can be categorized into two categories according to when the symptoms begin. The congenital group would be having the clinical symptoms present before the age of 1 year. So, if the patients have a history of constipation before the age of 1 year, that's always categorized as the congenital pathology. And the acquired would be always after the age of 10 years or adulthood as such. And the characteristic situation would be when you do the perrectal examination, the dilatation of the rectum could be felt as well as there will be tympanic note on percussion, resonant tympanic note on percussion with the history of constipation or irregular bowel movements. Now, many of the patients of megacolon may continue to pass the stools in small quantities, but there would be a backlog of the stools and this backlog of the stools often results in fecolith formations and that's how it could be felt. Now, the confirmation of the megacolony is always done by the investigations, and the choice of the investigation is a barium minimum X-ray or contrast X-ray is the choice of the investigation, which shows the dilated colon portion. Either it could be the distal portion or the whole of the colon could be dilated, and the presence of the fecal masses also can be confirmed as such. Now, basic difference between a congenital and the Hirschsprung's disease and acquired megacolony is in the Hirschsprung disease or congenital megacolon, the distal most part of the anus, rectum, rectoanal junction rather, would have an absence of the ganglia, and because of the absence of the ganglions there would be a spasm, and due to that spasm there will be the proximal dilatation, incomplete evacuation and the dilatation, and hence if you take the barium minimum X-ray, you will see the dilatation in the proximal portions of the rectum, but in the distal most area, that's near the anal junction, there will be a narrow pencil rod-like appearance. So it will be a pedicule-like, and then the dilatation of the rectum. Whereas in the acquired megacolon of any of the other causes, the dilatation reaches up to the anorectal junction. So the barium minimum X-ray, that tip of that dilated portion would be smooth bulge, like it's a bulging from the external opening itself. Whereas in case of the Hirschsprung's disease, there will be a small segment of a narrow lumen, then followed by the dilatation. So that it makes the difference between the congenital or what we call as the Hirschsprung's disease or the acquired megacolon as such. Now, as far as the management is concerned, in all these conditions, if at all there is a primary disease like diabetes mellitus and so on, they need to be treated. Now, along with that treatment, there is no question of any other specific management. The only management will be ensure that the bowel is emptied, and usually for emptying the bowel, osmotic laxatives are given, not the irritant laxatives. See, irritant laxatives are the substances like senna and so on, which are even castor oil. They are irritant laxatives, so they are not to be suggested. Rather, osmotic laxatives like powders, these these barn powders, etc. Such could be given, which will bulge the or which will add to the volume, or suppositories, or maybe even enemas, stop water enema, or can be often given. Or if there is a very hard stools, you may have to put in your finger and then extract. So that first mass has to be extracted, and once you have removed that mass, the next portions can be evacuated comparatively comfortably. And the patient has to be given a training for defecation. That's all the possible. And bulking agents like food should have more fibrous contents. But a better satisfactory treatment can be given with Gandhaka Rasayana Arogyavardhini Kumari as well. As we consider this as Agnimandya, and which I have treated many patients of that sort. Congenital, of course, it may not be possible to manage with the medicines alone. In old aged patients like diabetes and neurological conditions, Raja Panbastri can be quite useful in such patients. Then the next condition which we discuss would be the sprue malabsorption conditions. Among the malabsorption conditions, one disease is what we call as the tropical sprue. The name tropical sprue occurs because of the geographical distribution. Incidence of this condition is more around the tropical area, above the equator, and the geographical distribution of the tropical sprue also is typical. India is one of that geographical area where incidence of the tropical sprue is quite high, and hence from the clinical point of view it's an important condition. Tropical sprue is an important condition from our point of view. The real causes of the tropical sprue is again questionable. There is a lot of argument about that, but often it is believed that it could be due to a presence of infective organisms, multiple infective organisms, bacterial organisms. That's what the hypothesis says. But it could be due to even the food types of the food, irritant food substances consumed also. Food habits also could be a cause for the tropical sprue. Those who do not cook the food, particularly non-vegetarian food, which is not cooked properly, that can be a cause for the tropical sprue. Worm infestation also can be a factor which triggers the tropical sprue conditions. Typical clinical symptoms of the tropical sprue would be steatorrhea, that's a fatty stools, diarrhea, weight loss, swelling in the leg or edema in the legs, or abdominal swelling, the abdomen become bloated, or even there could be a hepatomegaly, marginal hepatomegaly, and fatigue, fever, irregular fever, totally weight loss. That's the most important. Patients of tropical sprue would show a remarkable weight loss, and when it occurs in the relatively younger age, there may be even a stunted growth. A frequently seen clinical entity is a hyperpigmentation of the palms. Now, if you look at the palm of such patients, the color could be blackish, or there could be even hyperkeratinization. Often gives a suspicion of a metallic toxicity, but the patient's metal levels may be normal. Of course, lead poisoning also can present with the similar clinical symptoms, where there will be hyperpigmentation as well as the diarrhea-like conditions. So that also is included under the tropical sprue conditions. The complications which can occur in the patients of tropical sprue would be: patient may have acute diarrhea, volume depletion, electrolyte imbalances, and anemia. The edema, pedal edema, of course, vitamin deficiencies also can be the other clinical symptoms as such. And the incidence is quite common. Its incidence is quite common in the rural population as such. The standard protocol of the treatment is tetracycline 250 milligram for up to 4 months, prolonged treatment. But usually tetracycline given for such a long time can even result in bone marrow depression and complications. And hence it's not a sufficient treatment. But the other part of the treatment will be supplementation of vitamins, vitamin B and folic acid. That's the standard protocol of the treatment. But what I have observed is a Agnisundi Andhapere Mustakarista or Draksharista given for a considerably long period can resolve the symptoms much better than tetracycline, and the clinical improvement will be quite significant. In very severe cases, Pichabasti also can be quite useful. So, tropical sprue, the one of the basic problem with the tropical sprue is there is no definite diagnostic criteria. The clinical symptom is the only criteria to make the diagnosis, and when you have ruled out other disease conditions, when the patient have these kinds of symptoms, when you have ruled out other conditions, then only it can be considered as a tropical sprue. Now, another disease which has a very similar clinical resemblance is the celiac disease. Now, celiac disease is a condition which resembles exactly the tropical sprue, but the only difference is it may not have that kind of a geographical distribution, and the cause is not due to the infective pathology. It could be due to the presence of the gluten in the food. Now, gluten is a simple issue, a protein which is naturally found in grains like wheat, barley and rye, and it acts like a binder. Actually, it's a gum-like. So that gum-like portion of the wheat or so on, when you grind the wheat, you know that there will be some gum-like substance. That is considered as gluten. Gluten is not a simple single protein. It is a complex protein containing many components, gliadin and glutamine, and when they are combined together, that results in gluten. Gluten is a complex protein of different types. And by nature, gluten is definitely not harmful. It's necessary for the body, but some of the people may be sensitive. Sensitive to the gluten is one of the issue which is common. And that sensitivity and harmful effects of the gluten will be more when the food is processed with that fine-tuned like powders, or where the powder, these grains are polished more. See, that excess of polished grains, even including the rice, that polishing would reduce many of the nutrients, and absence of the nutrients results in increased chance of the gluten toxicity. So polished grains or with the wheat, it's the powder is prepared with the extraction of that other substances, only adding this sticky substance which we call as maida. Maida is actually a modified flour of the wheat, and that kind of the substances, they increase chances of the gluten sensitivity, but it's not really seen if you use the crude and traditional methods of the food preparations. The clinical symptoms, of course, incidence of the gluten sensitivity is more common in western countries than in our nation, but now because the food habits have changed and the people who consume lot of junk food and modified food like these bread and so on, even bakery products, which is having made the incidence is now seen somewhat more frequently. Otherwise, conventionally, in our area, the incidence of gluten sensitivity would be less. The clinical symptoms are almost exactly like the sprue, tropical sprue. The other variations could be there is a patient with the frequent diarrhea, and often the patients may have that diarrhea related to the food. Certain specific food substances would aggravate the diarrhea. So, history of diarrhea is seen in 45 to 85% of the patients. In about 45 to a lower number of patients may have persistent diarrhea, always loose stools. Some may have the symptoms of loose stools related to certain specific food substances that is often presented as allergy to the food. Only certain specific food substances containing high level of protein, it may produce the diarrhea in some patients. Flatulence is another common symptom. A total bloated abdomen and loud sounds, barbarigme, that's loud peristaltic sounds also are seen in quite large number of patients. Weight loss is another quite common symptom, and particularly in children, there may be failure to thrive and growth retardation is common. Gluten sensitivity also is more common in children who are fed with the artificial food supplements or that milk, powdered milk like supplements also can trigger the gluten sensitivity in children. Other clinical symptoms are weakness and fatigue in majority of the patients with the poor nutrition. Abdominal pain also could be the other clinical symptoms as such. In addition to that, the extraintestinal symptoms can occur like anemia in a large number of patients, osteopenia, impaired growth of the bone, as well as osteoporosis could be seen in large number of patients. Neurological symptoms like motor weakness, numbness, or abnormality of the gain, rarely seizures also can develop. Skin disorders like patients may have dermatitis like conditions, pruritus, or skin rashes which looks like papillae or papillovesicular lesions, which can often produce confusion with some other issue. But all these are the typical sensitive reactions which can occur in the patients. Hormonal includes like amenorrhea, delayed menarche, and infertility in women, and impotency and infertility in men. These also can be the clinical symptoms in case of the gluten sensitivity issue. But of course, practically from the clinical point of view, the gluten sensitivity conditions are less common in our situation, whereas more common in the Western countries. Uh, Tropical sprue is more common in our situations. The other clinical signs are the patient may have a protuberant tympanic abdomen, the abdomen may be distended and there will be always a gaseous distance, weight loss, orthostatic hypotension also could be the other. Orthostatic hypotension means the range of pressure changes in the erect and lying down posture is more than 10 millimeters of mercury. Peripheral edema, also ecchymosis, that is the skin lesions, hyperkeratosis, and chelosis and glossitis. The tongue and the lips may have the changes like, and peripheral neuropathy. These are all the common clinical symptoms in all malabsorption conditions. Now, the general standard protocol of the treatment is as per the American College of Gastroenterology, the antibody testing, especially immunoglobulin A and anti-tissue transglutaminase tests are the best tests. But practically, we do not do these tests in majority of our conditions. If the patient says that there is a food allergy, we treat them as such. Then radiological signs of confirmation of the gluten sensitivity are the typical of the changes in the generational fold patterns, like they become more blunted. I'll show you some of the examples. The ileal fold thickening, the folds of the intestines is seen in the X-ray, would be seen to be thickened, the bowels would be dilated, and there could be even interceptions, repeat interceptions. Strictures also could be seen. There could be increase in the blood flow over the vessels, and if at all you do a ultrasonography, that can show that changes. Mesenteric lymph nodes also may be seen as a prominent one. There could be a splenic atrophy. These are the typical signs. Now, the typical signs of this is true in case of any malabsorption, including gluten sensitivity, would be the intestinal folds become more blunted. The ileal loops and jejunal loops, they seem to be more dilated. The surface characters of the ileal loops will be brush-like. That's the typical feature in all cases of malabsorption, including gluten sensitivity, and that's exactly the clinical features seen in case of the gluten sensitivity. If you do a barium follow through X-ray, barium follow through X-ray is the standard protocol, either plain X-ray or CT scan with the contrast. As a follow through protocol has to be done, and that confirms the malabsorption conditions. The management is there is there is a fashion, like there is a gluten free food. Now these days it has become a fashion. Every food product would have a label like it's gluten free, and that gluten free food itself could be quite harmful the other way, and it need not be advised to all persons. Only in those persons who are well known to have or very sure to have the gluten sensitivity, that gluten free foods could be suggested, but in others it's not. The common gluten free food substances which are used are like popcorn or maybe the oats and so on. These are the common food substances which are publicized as in the market. You get lots of such food substances with a label that it is a gluten free, and it is considered as a health food, but it's not, I remind that gluten free food is not a general health food. It's only for those persons who have a gluten sensitivity that these are recommended. For the common man, it's not recommended. Then the other part of the treatment will be symptomatic treatment, and maybe if the patients have very severe clinical symptoms, low dose of corticosteroids also are often used as such. From my clinical experience, we have treated a good number of patients with Agnitundi, Anandabhairavi, Mustakarishta or Jirakarishta. Mustakarishta in those patients who have more of diarrhea. Jirakarishta is in those patients who have distension of the abdomen. Gluten-free diet is not always advised, and the complications, harms which are due to the gluten-free diet are deficiencies of micronutrients. The patients may develop these deficiency symptoms of nourishment, and that itself could be a cause for the malnourishment. Hyperlipidemia, or even it can trigger the diabetes-like condition. Coronary diseases incidence also are more if you depend upon only gluten-free food, and that's why I stress upon that part. Gluten-free diet is not recommended as a general health promoting diet, but it's only recommended for those persons who have a proved gluten sensitivity. But unfortunately, the current trend has become like that every person is recommended gluten-free diet, and this has become a fashion, like consuming oat as a regular food. This has become a fashion that is not recommended, that should not be recommended, and it's better to depend upon the natural source of the food. Then the next is, again, all these are related issues. See, actually, to differentiate between tropical sprue, celiac sprue, or maybe the your malabsorption, general malabsorption would be quite difficult practically. All of them have a similar symptoms, but as far as based upon the causes, we categorize these diseases as the different categories. A malabsorption is a simple clinical presentation where the intestines are not able to absorb the symptoms, and that's also called as malabsorption syndromes. We usually name them as syndromes. Of course, many times tropical sprue and celiac sprue also are categorized as malabsorption syndromes, so they are a part of it. But from the general point of view, one of the practical clinical problem which we face would be patients having malabsorption. Now, malabsorption, based upon the pathology, They are categorized into three phases. Luminal phase, where the food is not properly digested or food is not presented to the intestines in a proper manner where it can absorb. That's due to the impaired nutrient hydrolysis. See, whatever the food you consume, it should be reaching the absorptive area of the intestines like jejunum and the ileum in a form in which it can be absorbed properly, and this is done by a regular process of adding on digestive juices, like in the stomach you add hydrochloric acid and other juices, and then the protein breaking enzymes, and by the time it reaches the intestines it should be in a situation where the substances can be absorbed. If this process is impaired, then it can result in malabsorption, and all that categories of the diseases are categorized as the luminal phase malabsorption conditions. Then mucosal phase is the capacity of the mucosal membrane of the intestines to absorb the substance property of these. Suppose if there is a atrophy of the mucosal layer, then the absorption may not occur, and that also results in malabsorption, and such malabsorption disease conditions are considered as the mucosal phase malabsorption conditions. And then the post-absorptive phase, if the absorbed substance cannot reach to the system properly through the chylous system, then it's the obstruction, this post-absorptive phase of malabsorption. So patients presenting with the malabsorption symptoms, they have to be thoroughly examined and investigated to identify the real cause of the malabsorption. And once you have identified the real cause of the malabsorption, the strategy of treating those patients would be very accurate. Otherwise, simply treating a patient of every malabsorption condition in the same line may not be practicable. The luminal phase malabsorption, where there is impaired nutrient hydrolysis, the most common causes are pancreatic insufficiency due to chronic pancreatitis. Patients of chronic pancreatitis tend to develop the malabsorption because the pancreatic enzymes are not able to break down the protein and fat, and hence the absorption doesn't occur. Where the patients have undergone pancreatic resection, cancer, or cystic fibrosis, and so on. Or the other causes, the most common is pancreatic insufficiency. The other causes could be even related to the type of the food you consume. See, normally the food would have a property of getting dissolved in the stomach easily. But when you add lot of preservatives to the food, that preservative containing food may not get hydrolyzed easily in the stomach because of the presence of the preservatives, which though they are categorized as inert substances, but they are not really inert. They really make the food less digestible, and hence even that condition. So those who eat junk food, those who eat all packed food, rather all packed food have a lesser capability of getting hydrolyzed compared to a food which is not packed or which is fresh. So that's the other way. Or the other conditions could be like patients who have a parenchymal liver disorders, like patients who have a disease of liver like cirrhosis, where the bile secretion is not proper, or the bile secretion being reduced due to these biliary obstructing pathologies of different sorts, and patients who have a impaired enterohepatic circulation. Enterohepatic circulation we have already discussed in the previous sessions, like a good amount of the bile is reabsorbed and bile salts are secreted. So this circulation of the bile salts and they help in this absorption of the fat substances, facilitate the fat absorption. And if the bile is not circulated, the quantity of the bile salts will be lesser, and hence the fat absorption may not occur properly. And of course, abnormality of the bile salt deconjugation as such. Mucosal phase is when there is a impaired brush border hydrolysis activity, and which could be produced due to the deficiency of specific enzymes and hormones like disaccharide deficiency, lactase deficiencies, IgA deficiency, autoimmune enteropathy. Now, these lactase deficiency and IgA deficiency could be congenital genetic pathologies, or they could be triggered due to certain medicines which are given. Or the decreased absorptive surface can occur in case of intestinal resections if the patient has undergone intestinal surgery. The mucosal phase also would be affected because the total area of the mucosa available for the absorption would be lesser. Or absorptive surface is damaged as in case of the tropical sprue, celiac sprue, or other diseases of the intestines like AIDS, enteropathy, chemotherapy, etc. Then infiltrating diseases of the intestinal wall, patients who have lymphoma or amyloidosis where there is a deposition of the substances or the lymphatic structure of the intestines are affected and the mucosa is inflamed, in that condition it may not be able to absorb. Infective diseases like bacterial pathology, giardiasis, etc. In these conditions too, because the mucosa is inflamed, there will not be a proper absorption. So the causes of mucosal phase malabsorption could be many. Then the post-absorptive conditions like where there is a obstruction to the lymphatic system, of course it can occur due to the congenital diseases, Milroy's disease, where there is a agenesis of the lymphatic system, and or even the diseases like tuberculosis, neoplasms, surgical interventions can affect the structure of the lymphatic system, and that can result in the malabsorption. So when a patient comes to with the symptom of malabsorption, it has to be investigated, or rather most of these can be done by a thorough clinical history taking, and with that history taking you can decide about the cause of malabsorption. Symptoms of the malabsorption are the most common are the diarrhea or steatorrhea, fatty stools or diarrhea. Weight loss and fatigue is the other most common symptoms. Flatulence, abdominal distension, edema, and all these typical clinical symptoms which we have discussed in the sprue also are common in every malabsorption syndrome conditions. It also can result in bleeding disorders because of the insufficient vitamin K absorption, and metabolic defects of the bones like osteopenia and osteomalacia, osteoporosis can occur. Neurological manifestations like motor weakness, peripheral neuropathy, or hypocalcemia, or vitamin deficiencies, chelosis, glossitis, and aphthous ulcers in the stomach. Chelosis and glossitis seen in malabsorption are very typical. Chelosis is where there could be hyperkeratinization at the angles of the mouth and there could be cracks on the lips, whereas the glossitis is seen with either coated tongue or bald tongue. So when you have this coated tongue or bald tongue or maybe the chelosis, you can make a diagnosis of malabsorption syndrome, and then you will have to confirm like what could be the real cause for the malabsorption. Whenever you can make out this real cause of the malabsorption, the management can be planned better. Now, the confirmation of the malabsorption can be done by barium follow-through X-ray, and characteristically the features of the malabsorption would be either there could be a faster evacuation of the barium. Barium may reach to the ileum within 2 hours, and the surface of the jejunum and the ileum seen in the barium follow-through would be quite characteristic, that there will be quite serrations. The barium would not stick uniformly, instead there will be multiple serrations as such, and the loops of the intestines would show a blunt curves, like very wider curves. So typical is seen in seen with the celiac disease, any sort of the celiac disease, or even in the sprue, the similar situation could occur. One more could be the barium could get flocculated, or barium may become foamy, and in some areas of the intestines the barium could remain as such. That's also the clinical symptoms seen in or radiological signs seen in the malabsorption conditions. Time taken for the evacuation of the barium also either could be very much delayed or there could be slow. Even after otherwise clinical evacuation of the barium, there could be retention of the barium somewhere. So these are the evidences of the barium follow through X-ray in case of any malabsorption syndromes. Treatment, of course, the nutritional support, and wherever you know the treatment causes, the causes have to be treated. Like if there is a inflammation of the colon, that needs to be treated. So there is nutritional support is the other way, like where the specific vitamin supply is the other way is given. But I have observed is a large number of such patients without even going for a specific diagnostic step. If you treat them with Arogya Kumaria, so which is the typical signs of the Grahani or Agnimandya, all these I would categorize as Grahani and Agnimandya. And where patients suffer, a malabsorption can be treated with a relatively broader approach of Aragyavardhini and Kumari Asava, and clinical outcome would be quite good. With this, we will conclude today. The next condition which we discuss will be appendicitis. It's a bit early today. Okay, we'll conclude today. We'll continue in the next session. If there are any questions, I'll try to answer, and then there are some questions. Persons who are sensitive to gluten and lactose, etc., can they be reversed? It's better not to try for the reversal. It's better to keep them, when you know that you are sensitive to a specific food substance, it's better to avoid that. Of course, I have seen a few of the patients who have become rather tolerant, but it's not a universal phenomenon. Generally, I don't recommend the patients to test like whether they have become less sensitive or not. But there are certain patients, I have seen a few of the patients who have become absolutely non-sensitive to the substances which were for which they were sensitive earlier, like wheat products, milk, and so on. Many of the patients who are intolerant to milk now have become tolerant to milk, but it's not a very uniform result, right? So hence I won't suggest that. Then how malabsorption symptoms can be differentiated from CA, like term colon, how to differentiate. So that investigations are the only means. So whenever you have, because the clinical symptoms are similar, in all such conditions you will have to go for the investigations. For CA, either these contrast X-rays or CT, MRI, they can help, or if at all still it's not possible, CEA, that carcinoembryonic antigen study, or alpha fetoprotein study, tumor markers, can make out the difference. So when clinical diagnosis is not possible, so particularly the intestinal disorders, the clinical diagnosis is always difficult, and that's why in surgery the abdomen is considered as a Pandora's box. So actual diagnosis of abdominal diseases is always difficult, and whenever there is a suspicion, you need to go for the investigations, and the investigations would be of different choices. So most of the times MRI scan can give you a better clue, and if necessary you may go for the tumor markers. Tumor markers are not very sensitive, but when they can give a balance of the suspicion, like so your probable diagnosis can have more weightage with the tumor markers. Then whether it triggers in diabetic patients, what is the treatment? See, that's it. See, when the symptoms occur in the diabetes patients, the primary treatment would be the diabetes. Diabetes should be controlled, and then the same treatment, same protocol of whatever we have discussed, like. And what I would prefer would be same Aragyavardhini is or maybe Kumari Asava, Agnithundi. The Agnimandya treatment would be the preferred treatment, provided the diabetes is controlled. So control of the diabetes is the primary there in such patients, some diabetes mellitus. Okay, right? Then no more questions. So we'll wind up today. Next we will continue with the appendicitis and related issues. Right.